I will take questions for the next 10 minutes from somebody in the audience. Kindly put up your hand. David or mic kodi. Mic kodli karadridara. Please give him the mic. Please introduce yourself and address the question to the gentleman or lady whom you would like to.
My name is Dr. Giridhar Babu. I work for Public Health Foundation of India's Bangalore wing. I have two questions. One is for Dr. Mohan Raj. Second is for Ms. Aditi. Sir, Dr. Mohan Raj, sir. I had some problems with the method used for the estimation, especially in calculating the total missed deaths. The Chandrasekhar-Deming method assumes that these are the independent samples. So did you test for the independence of the samples while calculating this? Because I thought that is an overestimation. The next question is regarding institutional deliveries. When you said CAG report, I did not get the long form and what does it mean and where the source is. And in one of my students did the study in a similar setup, and then what we found out was most of the deliveries were being referred to either the quacks or the RMPs by the local health workers because of some nexus. And then from there, the delay would occur in reaching the district hospital or the taluk hospitals. And PPH is one in setting, is the common finding what we found in our study. So did you find anything similar in your study regarding that?
Chandrasekhar-Deming method.
Yeah, Dr. Giridhar Babu, I am not a biostatistician, I am only a doctor. But before using this formula, I have consulted several epidemiologists and biostatisticians. They said this calculation pattern is quite okay. I think any biostatistician, present in the crowd may give opinion on that.
Okay, my answer to your question. The CAG report is the report brought out by the Comptroller and Auditor General. What they did was to work with the official reported data from the health department. And therefore, the argument that we made, which is about the better reporting now, that is seeming like the number of deaths have actually increased. I was interested in your comment about the referrals to informal providers. We used to find that happening before NRHM. RMPs would play quite a big role in the delivery, which was quite a surprise to us, because they would come, give the injections, and the DAI would do the delivery. But that practice that has changed, and the verbal autopsies are showing a very distinct shift in where women are going. And these are all the women who were referred first to a PHC. And that's largely because of the ASHAs, the push by ASHAs towards the institutional delivery. So I think there may be regional variations, and certainly in this respect, our experiences seem different.
Somebody else had a question? Yes.
Yeah, I'm Shankar Prinja from School of Public Health in PGI, Chandigarh. My question is from Dr. Devadasan. I agree that the findings were preliminary and from the survey. In terms of looking at the processes, you had used an indicator which was the OPD contact rate per 1,000 population per year. My doubt was that we've done a similar kind of an analysis in Haryana and Punjab states, and what we found was that if we use this kind of an indicator, it actually reflects on both the inputs and the processes, because it also reflects on the lower number of professionals, health professionals in the first place. So if the doctors are less, so obviously the contacts is going to be less. And what we instead found was that if we look at the number of patients looked at by an in the OPD by a doctor in a given day, that gives a much more better reflection of the functionality of the doctor, and that thus is a better reflection of the processes, because it then tells us that the public sector is actually functioning good. Whereas if you look at in this perspective, it looks like as the public sector is not performing good, and the problem then is more now of governance and more of putting in more money and more inputs into the health system.
Yeah, point well taken. Point well taken. Yes.
Yeah, this question is for Aditi. I'm glad that there is a solid data which you have showed.
Can you kindly introduce yourself, sir?
Yeah, I'm Dr. P.H. Rao from an organization called STEM in Bangalore. I've been asking this question myself: is institutional deliveries reducing maternal mortality rate. I think there is a lot of data available which we are uncomfortable at looking at it because the answers are quite. My question to you is, I think it's not delivering. The institutional deliveries are not delivering in terms of reducing the maternal mortality rate. Should we continue with a program which is not delivering, and more importantly, which is not sustainable over a period of time? How many years you are going to pay the women to get her delivered some 1,500, 1,600, 2,000 rupees? How long can we do this? So what is your suggestion? Should we go ahead with it, drop it, modify it? What is to be done?
I think it's not, I mean, the trouble with us is that we sometimes throw away the baby with the bathwater. What the evidence very clearly shows is that while institutional deliveries might be necessary or good, they are not sufficient if quality of care does not improve. And quality of care means improving the capacity, knowledge, skills of the workers who are dealing with deliveries in PHCs and CHCs, specifically their knowledge to identify risk, to identify complications, and to manage, and to effect good referrals. Now, all of those things need to improve before we will start seeing a reduction in the mortality rate. The second thing is that in districts like Koppal, and in fact, a lot of the northern districts of Karnataka, there's a very high level of risk. And therefore, to focus entirely on the delivery period and not on the period before that is also inadequate. So we desperately need a good system of risk identification and management. And that again means strengthening the knowledge of village level providers, staff nurses, improving their access to screening technologies, and also to have a system of risk management which includes looking at data, having a system of monitoring progress, seeing whether treatment is actually resulting in an improvement, for example, in hemoglobin. So the two together, I think, will help in terms of reducing maternal mortality.
Last two questions, one from the lady, one from the gentleman.
Hello, I'm Dr. Venkatesh, working in Siddhartha Medical College in the Department of Community Medicine. This is not a question, this is the point with regard to Dr. Sanat Kumar, who mentioned about lack of treatment, standard treatment guidelines. Under the Ministry of Health and Family Welfare, there is a minimum standard treatment guidelines with regard to the common local conditions which the medical officers come across at the primary health centers, which we need to get updated, and different systems, let's say state health systems also should get this and pass it on to the respective medical officers so that it'll ease that small quotient also. So that's what the comment I wanted to pass on.
Yes, I agree that many our colleagues or doctors are practicing irrational use of medicines, so that we need to refresh them and trainings and give the treatment guidelines, because every patient we don't need to give antibiotics. So many other countries, they are following very strict guidelines. They have a committees who is prescribing more antibiotics. They have ethical committees. So we don't have that. So we can curtail the more irrational use of drugs.
The lady there.
I am Dr. Khadija from Padma Shri School of Public Health. My question is, there is a huge focus on institutional deliveries. What is it that is institutional deliveries going to reduce the maternal mortality and infant mortality, or skilled birth attendants will do the miracle? I mean, because institutional deliveries, institutions are not working 24/7, and moreover, many of them are not willing to go to the institutions. Why not provide skilled birth attendants at home? Home deliveries can be.
Yeah.
See, skilled birth attendance is very good if you are working in a situation, environment where you can evacuate the woman to a place where emergency obstetric care can be provided. Very good if it's in Western Europe or US where there's emergency transport round the clock. But in our country, if you're talking of a village which is 10 kilometers away and it takes 2 hours to reach the particular hospital, then I think just home delivery or skilled birth attendant may not be the answer. And there have been evidence from 1997 onwards when the first systematic review was done, which shows that you may have 100% ANC coverage, very good ANC coverage, but if you don't have basic emergency obstetric care with all the facilities, your maternal mortality will not come down. This has been done across many countries, low income, high income, middle income, and so there is evidence to show that you need institutional deliveries, you need that backup, institutional backup to save the women's lives.
Yeah. Sudarshan Saab, you are there. You are a person who has done so much. If there is anything you would like to say.
Just for clarification about the institution, when we say we need to define what are these institutions, whether a sub-center is an institution or a PHC, and PHC is it 24/7 or an FRU. I think we need to define this. This term institution is very misleading. When people said institution with which the evidence has developed is institution with proper facilities to provide for the complications. Yes. So now unfortunately we didn't define, NRHM did not define what this institution is. They were only talking about a traditional birth attendant, shift them to an institution, including sub-centers were considered as an institution. That was a very terrible mistake which NRHM made. So when we say, for me, safe delivery by a skilled birth attendant at 24/7 PHC with 3 staff nurses and with a facility, transport facility for emergencies for an FRU, functional FRU. I think that's the type of institution we should be talking about. Thank you.
Thank you. Ladies and gentlemen, it's been very educative for me also. I really liked the aphorism which Madam said. You can't throw out the baby with the bath water. It's absolutely that. I've worked in finance department. I've done 3 budgets. Money is not the shortfall for us, because 4,000, 4,500 crores is our health budget. And any incremental thing also, maybe if I put in incremental incentive to somebody or even institution I support, it's a couple of 100 crores more. It is equivalent to 1 Gandori Nala project for us. So basically 1 lakh crore, 1 lakh 2,000 crore. Money is not the issue. Let's get that straight. Secondly, presently the NRHM budget for Karnataka is about 1,100 crores, followed by KHSDRP is 200 crores. So I'm handling 1,300. This year the resource envelope is going to jump by 30%. So it's 1,500, 1,600 crores. Rightly, we have to put systems in place, people in place. Thirdly, how do we incentivize people? Because research has shown everywhere, incentives help, some positive incentives. We may feel it's very great, but at a macro level, they are not so much. So I'm very grateful to the Institute of Public Health, Mr. Devdasan, Madam Aditya here, Mr. Mohan Raj and Mr. Sanat Kumar for being panelists on this forum. I also thank you for patiently hearing us through. I think further such occasion should be there. Mr. Devdasan, you've taken a lot of effort. I think we should commend you for that. Thank you very much. Thank you for being here.